This week, we're going to talk about assessing and monitoring GLP-1 patients. And normal format, I will go through a number of slides and then obviously open it up for questions at the end. So let's go ahead and get started. If you have any issues with hearing me or seeing, the screen, just let me know or put something in the chat. But I think everything seems to be working just fine. Okay, so the agenda for today, we're going to talk about key metrics for evaluating the effectiveness of GLP-1s. We will talk about dosing adjustments. We will talk about patient self-monitoring tools, follow-up management tips, and common symptom tips and tricks. So I do want to set the stage because I am a registered dietitian, nutritionist. My big focus is really, functional and integrative health. And I do own the medical weight loss clinic. So how we work with patients is going to be different than how you would work with patients. And as I was kind of reviewing my presentation, I wanted to kind of like set the stage for the differences because the approach will be a little bit different for most people. So owning the business and obviously medical, so we utilize these GLPs, I mean, obviously, but we're involved with the patient from the beginning to the end. So that means, we're having the initial consultation, we're reviewing their medical history, we're doing medical assessments, we're starting the patient, on the medication, we're educating them on the medication, and we're dispensing it from our location. And then we're setting up different follow-ups as we go along. So again, we have a very good idea of what is going on, with the patient prior to starting the GLPs. So for dietitians, and again, I would love to open this up at the end and really hear more about how you're getting patients. But a patient is going to be referred to you. Is going to be referred to you for a number of different reasons. So they're either on the medication already, or maybe they're just starting the medication. Some people may have been on the medication for a long period of time, and you're kind of coming in and you have to kind of reset and assess and kind of see where the patient is at and that type of thing. Really having to adapt to where they're at. And then, there's that part of, who are they working with? Was their doctor or nurse practitioner assisting in some way? What were they being told? How were they being supported? And how is that going to kind of align with your approach? So really, I guess the point of this is really kind of taking a step back and kind of making sure like all those pieces are put into place and really collaborating with not only the patient, but obviously maybe, in some instances, other practitioners that have been working with them. So just like a new patient, if somebody was sent to me, and people are coming to us from other places, they were doing it online or they were doing it we just had someone walk in that was getting their GLPs from a vein clinic, right? So they weren't being managed, they were just given the medication. So our approach is always treating a new person as a new patient. So we are reviewing the medical and nutrition history. We are, and that would be different from someone that was prescribed it and they're already on it. A doctor prescribed to them and now they're seeing you. The example I gave wasn't that exactly, but hopefully you kind of understand the point of like, no matter where the patient is coming from, you want to kind of reassess that patient as a whole. So again, looking at their medical history, nutrition history, assessing for any contraindications or precautionary conditions, because oftentimes things can be missed. And, now we've really started to learn a lot about what type of patients don't do as well. So really assessing their current state of health, their symptomatology, and reviewing their patient goals and expectations. Obtaining the baseline information includes, a medical and nutrition history. We have talked about the symptoms, symptom assessment surveys that we use on a regular basis, but this is, in our opinion, one of the most important pieces, to bring into when managing patients. Are you able to get their labs? We don't always have access to labs, but when you can get labs from, if they had them within like 3 to 6 months, that's still going to be that's going to be helpful. And we do labs at one of my locations. We don't do them at all of the locations. And I will tell you that labs really have been a game changer for a lot of different reasons. But don't get me wrong, you can still help people without having all of that information. You'll want to know what has worked for patients in the past, what has not worked. Are they coming to you because, they were on a GLP, they didn't do well with it, so now they're switched to another one. And so they want someone to manage them more closely with like their nutrition and stuff like that. So really kind of again, getting a good understanding of the scenario of the patient picture. So by now, I think most of us understand that GLPs are designed to address metabolic dysfunction. So they do many different things to help metabolic dysfunction. They improve insulin resistance. They improve the GLP signaling. So hopefully, just based on like the other presentations, we explained how it does all of that. They improve energy balance, they decrease inflammation in the body, and they increase muscle synthesis. So with all of that, I mean, that absolutely paints the picture of improvement in one's metabolic health. So who is a candidate? These medications are not just about weight loss, right? I mean, as I talked about before, obesity is just a result or a symptom of metabolic dysfunction. Metabolic dysfunction, it manifests in so many different ways, and it could be 10, 15 years before something actually starts to show up on a medical exam or some type of labs. So these are some ideal diagnoses that, people are going to respond really well to these, obviously pre-diabetes, PCOS, fatty liver disease, dementia, weight loss resistance, autoimmune disease. Really, all disease begins with metabolic dysfunction. And then it really just depends on how severe the metabolic dysfunction gets and really what's your body's propensity to develop certain diseases, based on genetics and that type of thing, where that ends up falling. But the point is that, is there an opportunity to address metabolic issues or metabolic dysfunction a little bit earlier? And again, these diagnoses are, advanced metabolic dysfunction. So they're obviously those types of patients are going to be really good candidates. GLP-1s have many, many benefits. Again, I know I'm kind of like reiterating a lot of things that we talk about often, but it is important to understand that these GLP injections, semaglutide, tirzepatide, they are designed to signal to many receptors throughout the body. And that when the receptors are signaled, there is multiple benefits. And you can spend a lot of time just on this slide and kind of look at each area of the body and how it's affected by the signaling of GLPs. But what the big things that we have seen outside of weight loss is a decrease in pain, a decrease in food noise, increase in energy, increase in concentration and focus, decrease in desire for alcohol, some change in taste preferences. People actually report that they don't like, believe it or not, like unhealthy food anymore. Like the fast food, processed food isn't as appealing and to people once they start taking the GLPs. That happens for a handful of people. I'm not saying it happens to everyone. We have heard that people have improved sleep since taking this. So of course, you could get these one-off benefits, but when we're working with people, we're constantly working on getting the body into a healthier state. So is it the GLPs per se, or is it just the body getting into that healthier state? We do see things happen so quickly, so there's definitely a benefit to just the GLP ones. And then we have our GIPs. So, okay, so semaglutide is the single agonist. Tirzepatide is the dual agonist. So tirzepatide hits the GIP receptors and the GIP. So it is a more comprehensive kind of mechanism. And again, you can kind of see the image that I have there that kind of breaks down in different areas of the body, how they affect one another. But what's important to understand is that the GLP and the GIP, they actually work very synergistically, and it is more physiologic. So, when GLP is signaled in the body, it happens when it's supposed to happen when we consume food. The GLP-1 is not signaled on its own. It always has GIP involved. So the tirzepatide being a dual mechanism, it is more physiologic. So that's something to keep in mind, and we'll talk a little bit more about that. But the GIPs, or tirzepatide, Mounjaro, and Zepbound, they're released from different part in the gut. So the enteroendocrine cells, so the K cells in the upper intestines, and then the jejunum and duodenum, versus the colon and the ileum from semaglutide. So again, it is a little bit more comprehensive with where it's hitting certain receptors in the gut. Tirzepatide has shown to have a greater impact on mobilizing fats. There is research showing that it improves bone strength. It seems to have a better effect for those who are dealing with PCOS. So fertility improves when, certain patients start to have PCOS, start to lose weight, things, in that category. The other really important thing about tirzepatide is that it does have less of an effect on gut motility. So obviously some of the most, significant side effects that people experience is GI side effects. And so if somebody really can't tolerate like semaglutide, we'll usually switch them to tirzepatide, and they generally do really well because it just doesn't have that much of effect on the motility aspect of it. And like I said, tirzepatide is definitely more physiologic. Retatrutide is the triple agonist, and we will talk more about this, I think, at the last session, but this is not approved for use yet. It's still in clinical trials, but it will be coming out very, very soon. And retatrutide, it will release the GIP, the GLP, and it signals to glucagon as well. So again, even more synergistic than the tirzepatide. So this area of medicine is ever evolving. There's probably over 30 different medications right now in the pipeline. And again, we do talk about this in, I think, like a bonus presentation, but just kind of know that this is likely to be the next one that hits the market. Okay, so self-monitoring and accountability. So we definitely want to make sure that we're doing our job to monitor the right metrics, monitor the right things when trying to help patients. But it is so important for patients to be accountable as well. I think just as dietitians, we're so used to having to create and plan and tell people what they should be doing when that really does it really doesn't do a whole lot. I mean, it's kind of like that motivational interviewing. We really have to put some ownership on the patient and have them, think about things for themselves, right? Because only they know what is going to work for them, what's going to be sustainable, what is the thing that is their angst, the thorn in their side that we would never know, right? So really being able to have that dialogue, that interviewing skill set to really again put it on them, ask them what they should be doing, and kind of coming up with goals that way. But I'm gonna run through obviously some things that we use. So diet logging, the dietitian's, like favorite tool. I mean, I do love it, but obviously it's can be very, very subjective. So knowing what the patient is eating, and not only that, again, holding them accountable for it, doing weight and body composition measurements and checks, doing ongoing symptom assessments. We have every single time a patient comes in for a follow-up, they get an automated symptom assessment form. So we can get a snapshot of if things have changed along the way or because of the titration and things like that. So I will talk a little bit more about that, but and we will be providing you our symptom assessment that we use, but this really truly is a big piece to monitoring patients on GLPs. You can also consider using CGMs. That can be so beneficial on so many different levels. We did a separate webinar on that with Karen Kennedy. Really focusing on the foundational behaviors is really crucial too, because I think one thing that we noticed was patients were coming in and they were losing weight, then they would kind of stabilize, and it was kind of like for periods of time they kind of got stuck in the cycle of weight gain, rate, weight gain, weight loss, that type of thing. So we wanted to really hone in on some of the foundational behaviors that the patient was doing. And so now this is something that we will talk to them about every single time, and we actually do add it in our symptom assessment, is how often are you following, the diet guidelines that we recommend? How often are you following the exercise recommendations that we had recommended? What does your sleep and stress behaviors look like? And so they have to rate themselves. So if we're trying to focus so much on, let's say, for some reason we're just focusing so much on the diet, we only want to, hone in on that. We want to cut the carbs, we want to do that. But at the same time, this patient is, going through a divorce, they started a new job, and they're, dealing with all this other stuff. Well, you're not really going to get very far in one area if you aren't kind of looking at the full picture and able to kind of take a step back and say, okay, listen, let's try to talk about this area and see if we can, set some goals or, come up with a plan for what you're going through right now. So follow-ups obviously are crucial. We put together many different protocols for follow-ups, and this is something that you can think about as well, especially as you start to see more people and you kind of get a better idea of what they're presenting with and what their issues are, their problems, and that type of thing. So the most important thing is really determining the frequency of the follow-ups. We've heard the gamut of some patients that, got they were put on the GLP and then they are supposed to follow up in 3 months. Like that to me is totally crazy. So biweekly appointments, in my opinion, at the beginning is crucial, especially if a patient just starts the GLPs because you're titrating or they're titrating, you're working with the patient as they're going up in dose. So that's like the trickiest part because the dosing guidelines are kind of like, set in stone. I mean, most people are understanding that it's a guideline and it's not designed for every single person because everyone's different. But it really is an opportunity for you to really help the patient work through certain things that they might be experiencing. Automating assessment forms whenever possible, just so patients can regularly expect to do that. Our assessment forms it will probably take 10 to 15 seconds to complete, so it's not like and they're all automated and they just click a button. So that's always helpful, but kind of looking at your current situation, what would be the best way to do regular assessments, while they're on the medication. As you're working with people, you know, there are going to be times when they start thinking about going off of the medication. Or maybe, they've been on it for a while and it's no longer working. Or they've heard something about a different product and, they want your recommendations or advice on switching to a different product based on what they're experiencing. So these are really all things that we need to be prepared to have those conversations, as they come up. So this is just a snapshot of the dosing regimens for semaglutide and tirzepatide, as you can see. I mean, I'm sure you've seen this a million times over. But and again, it would be another thing I would love to hear from you all. How often are you involved in having those conversations about dosing, or is it really more the management of like making sure, the food and the diet looks good, the exercise and that type of thing. But you can see that I don't know how important this is, but essentially, Ozempic and Wegovy is semaglutide, and the dosing is almost identical. It's not exactly the same, but if they're getting the pens, the Ozempic or the Wegovy pens, it's a very similar titration. You can see that Ozempic for type 2 diabetes, the max dose is 2 milligrams, whereas Wegovy for weight loss is 2.4. So again, it's just slightly different. I don't think there was any rhyme or reason for that. I think it was just in order to get a different indication, they had to kind of change up the dosing a bit. And then Mounjaro and Zepbound. So Mounjaro, the compound is tirzepatide, is obviously approved for diabetes, and then Zepbound for weight loss. And these are identical dosing regimens with like some slight nuances. So understanding the dosing, is I still carry around certain charts because it can get really confusing, especially if you are seeing patients that come to you who are on compounding medications. We use compounding medications, so we don't use these exact dosing schedules at all. I mean, they're somewhat similar, but we've changed things up a bit. And so if patients are on compounding medications, they're going to be getting their medication in a syringe versus a pen, which we're going to talk more about. Okay, so dosing is absolutely an art, and it's not a direct science. And again, just reiterating the fact that just because a patient is on month 2 doesn't mean they need to be on month 2 dose. So it is all about kind of assessing the situation. So as a dietitian, seeing GLP patients, again, if they were put on it by another MD or another practitioner, I think it's really important to have those expectations with the provider, specific to your role on, conversations about dosing. I think most people that send patients to dietitians just think that we're just going to work on their diet. And I think it really warrants, opening up that conversation with the referring practitioner to say, listen, this is what I can help with. What are you comfortable with? I mean, and kind of like come up with a plan. Find out from the patient how they're administering their medication. So again, is it a pen? Is it a syringe? Or maybe it's the oral semaglutide, you really kind of gaining clarity there. Discussing milligrams versus units. We're so used to using units in the insulin syringes, and the units really mean nothing because 10 units of a 50 milligram vial is going to be very different from, 10 units of a 25 milligram vial. So really get in the habit of using milligrams with patients, because then that's apples to apples. You're not having to convert and try to figure out like what's the actual dose of this medication in the compounding pharmacy. So using the milligrams is the best way to go. What dose is the patient currently on? Are they on a super low dose? Are they on a high dose? How long have they been on the medication? Because that is a big piece to dosing. When patients are on it for a period of time, you're going to see things totally change. And the body will, we talked a lot about this in the first one, just about saturation, plateaus and that type of thing. So finding out how long they've been on it. And I think what's also important, because we're seeing it all the time too, it's not just like, how long have you been on it this time? Because people are stopping and starting all the time now. And even though they may have been on it for a couple weeks when they came into you, they might have been on it for a year, a month ago, so really kind of getting that history of that. What are their current, symptoms, because the symptoms are going to drive the dose. If there are significant symptoms, the dose has to be addressed, because these medications can do so much good, but they can do so much bad if the dose is wrong. And it's like anything else. It's like any other, medication that is really helpful for a medical condition. It's like a thyroid medication. If you're on a super high dose, you're not going to feel so great. So it's kind of the same concept. Is the patient losing weight or plateauing? And we're kind of assessing certain things as patients come in, when we're trying to determine if we go up in dose. And it basically comes to three main things. Are you losing weight? What do your symptoms look like? And oh my gosh, I'm just blanking on the other one. Oh, how do they feel, right? How do they feel? Is it helping them? Meaning, and we're going to talk about like the hunger thing at the end, but this is like a tricky part, because if you say to them like, how is your hunger? Are you able to, you know, avoid certain temptations at work? You said last time that your coworkers bring donuts and stuff like that. Is it helping you kind of, pass situations like that up? So it's coming up with some verbiage, because the goal is not to obliterate people's hunger, right? That is not going to teach them very much. So it's kind of like that fine line, if and weighing all of the different components that are coming into it. If someone is their hunger is completely suppressed, but they're dealing with a lot of side effects, well, that to me right away, I'm either keeping them at the same dose or we're going lower. So again, there's so many different scenarios, and we're going to talk about it in case studies and things like that. But again, just kind of thinking about different things that could come up. When somebody is experiencing different side effects. You you can you can play with the injections. You can talk to them about skipping a week. You can divide the dose. So I know it's a once a week injection, but let's say a patient is on 1 milligram of semaglutide and they really like that, but it gives them side effects. So what we've been starting to do is we're dividing up the 1 milligram into 2.5s, and they take that, on like a Monday and a Thursday, and the side effects completely go away. So there's different ways to play with things. I mean, we do low dose, we do microdosing. If someone took an injection and they still feel like they have zero hunger for over a week, I'm like, don't take it for another 2 weeks. So just not to overwhelm, but just to understand that this isn't like a medication that it's like you have to take it on day 7. That's not how this works. And when it's time to wean off of the medication, there are various ways to do that as well. And so our approach is we taper down. And then we offer maintenance doses. So we do like different types of really low dose for longer periods of time. Just note that the medication does stay in the system for about 30 days. So if somebody does stop cold turkey, they're like, I'm done. I just, for whatever reason, they're going to be traveling. They don't want to do any type of weaning or anything like that. It's fine. It's actually okay. They might get some of the rebound stuff, a little bit quicker, meaning the hunger, the food noise and things like that. But if they have worked on the other stuff and they're in a healthier state, usually they can wean off of it just perfectly fine. I just put this in here because I just wanted to give an example of how dosing can get confusing. Because so this is a semaglutide. The starting dose is 0.25. The dose in the mill is 10 units, 0.1 mil, right? So again, one of our semaglutide vials, 0.25 milligram is actually 5 units. So it just reiterates the point of don't trust like the units, just really focus on the milligrams. Okay, so patients can inject in 3 different areas. So these are subcutaneous injection sites. And obviously, okay, so the abdomen is the most common, right? In the fatty part, away from the belly button. I always tell people like 4 fingers to the right or the left, and just you kind of grab an area and you inject, and that's the very common area. But you can also do it, they can inject on their thigh, and they can also inject in the bottom, like the upper arm area, or the side or the back of the upper arm. And so a couple of things. I was interested. I looked into what effect the different areas would have on the effectiveness of the injection. So I'm just going to kind of highlight certain things because I know this is a busy slide. So the abdomen is obviously often preferred. It has a large surface area and it's easy to access. There are some studies showing that it does have faster absorption rates compared to the other areas. And patients often find that the abdomen is the less painful area. I don't know if any of you have done subcutaneous injections, but they're pretty painless. I mean, I know there are some patients that are very fearful, but I've used peptides and subcutaneous injections in many different areas, and it's not painful at all. But I would say that yeah, the abdomen is virtually painless. So the thigh is another area for a GLP injection. And again, it's easy to access. Some people might like it. Absorption would be a little bit slower compared to the abdomen. So some people might feel that, right? Maybe they're looking for more of like an appetite suppressing component a little bit quicker, but they're noticing that since they switched the site, it's a little bit different. So just kind of be mindful of that. On the thigh, the site might be beneficial. Well, I kind of already mentioned this. It's easy to access. I mean, they're all pretty easy to access except for the underarm. That's almost impossible to do on your own. You'd have to have, it be in a setting where someone can do it for you. The upper arm is less commonly used, but it is an option. Some people will get like little bruises and they're supposed to move things around and oftentimes they'll just move it around in the abdomen area. But some people like to try a different area. So again, just note that these are all totally viable options. The upper arm is a moderate, has a more moderate absorption rate. So again, they might notice a difference if they switch to the upper arm. And again, it could be more preferred in like a clinical setting because you don't have to like take the blanket off and, bring, undress a little bit for your abdomen and you just kind of use your arm. One thing I did here, and I was trying to find a study that looked a little bit deeper into it, but I couldn't find it. Something to think about is the abdomen. So switching if there's side effects, and what one small study showed is that switching to the thigh actually lessen the GI side effects. So it would be an option to try if somebody is really having a lot of side effects on the current dose and where they're currently injecting. Okay, so we're going to talk a little bit about muscle mass and body composition. And I do say it a lot. I just feel like if you're helping someone lose weight and you're not looking at their body composition metrics, you really can't like really say that you're truly helping them because you don't really know if you are. If you don't know if it's the fat, it's the muscle and that type of thing. So obviously weight, body fat, visceral fat, muscle mass is the weight loss, fluid retention, and inflammation. So there's many different components. We look at all of it. We have the in-body, which is most people are familiar with it. It's a body composition analysis scale. So we'll dig a little bit deeper into some of the metrics. Our scale actually measures visceral fat. It measures the actual, what is it? Something meters squared. So it acts like the size of the fat that surrounds and infiltrates in the visceral area. The visceral fat needs to be a priority because it truly is foundational to metabolic dysfunction. If you still have a lot of visceral fat, and again, you can do a waist circumference and get a really good idea if your visceral fat is too high. And what is it, 35 for women, above 35 inches for women and 40 inches for men. That there's inflammation in the body. There's probably some insulin, sensitivity, maybe even insulin resistance because that is what it has a propensity to do. The hormones it completely causes a imbalance in certain hormones like the stress hormones, the cortisol hormones. So people that have more visceral fat are complaining of sugar cravings. They're hungry. They can't sleep at night. Their body is they feel stressed all the time with just little situations because their bucket is too full. And when you have a lot of visceral fat, you are in a very, very stressed state just from being in that overweight state. So everything else is just a compounding that issue. So being able to really measure that as you're working with someone is really important. And then there's muscle mass. So signs that someone is losing muscle, they might report that they're just getting more tired, they feel weaker, they feel it in their muscles, are getting smaller. If it's an older patient, maybe they're having more balance issues. I mean, hair loss can be a sign. And then people that report a decrease in exercise of endurance and strength is a really obvious sign as well. I debated keeping this slide up, but I wanted to just run through. This is kind of what's out there as like a summary of GLPs and their effect on weight loss. And then I'm going to dig more into like what the research shows. But if you do kind of a search, like a Google search, and just want to get an idea, do GLPs cause muscle mass? You're gonna get you'll get a bunch of different kind of looks at the summaries of the research. Okay. So research, GLP receptor agonist and muscle mass reveals a complex and contradictory findings. So some studies indicate that they are protective or offer neutral effects on muscle mass, especially under specific conditions. Some studies have observed that muscle mass with GLPs is often linked to significant weight reduction, often affecting both fat and lean mass. Appetite suppression and delayed gastric emptying can reduce protein intake, therefore affecting muscle mass. We all kind of know this. Like everyone's like, they're losing weight or they're losing muscle because they're not eating enough protein. So we know a lot of this stuff. Some evidence suggests that GLPs may preferentially target fat mass reduction. Body composition analysis sometimes shows more fat loss than lean mass with GLPs. Interaction with exercise, resistance training is crucial. Again, I'm just saying this because we kind of know it, but this is what's continuously being communicated. Factors like age, baseline, body comp, comorbidities, and GLP dosage is going to influence outcomes as well. Okay, so just kind of bringing us all on a level playing field here. Let's dig deeper into how GLPs affect muscle mass. And another great kind of open dialogue that if someone has some thoughts on this area, I would love to kind of hear more about that. So improved insulin sensitivity allows the body to better utilize glucose for energy. So that is going to anytime insulin resistance begins in the muscle, right? So if you can start to repair that, you're going to get more muscle, more protein synthesis. The increased efficiency can contribute to better muscle function and performance. So now, that can support a growing muscle as well because now it's working and functioning better. GLP medications also help prevent the catabolic effects of prolonged hyperglycemia, which can lead to muscle breakdown. Some studies suggest that GLP medications may stimulate protein synthesis in muscle tissue, and that's like independent of exercise. And research also is showing that GLP medications can promote bone development as well. So anytime you can fix the foundation of metabolic dysfunction, which is blood sugar imbalance, dysregulation, the body's going to respond positively for that. And it is the exact same thing what happens in the muscle. There's a study that looked at myostatin and muscle mass. So myostatin is a protein that actually inhibits muscle growth. And so these GLPs have been shown to reduce myostatin activity, and that obviously is going to help promote muscle growth. Myostatin usually decreases as we age, and that is one of the main contributors to why we just lose muscle as we age. And so there are now products out there. We actually offer a specific product that I talk more about. I don't think I talk about it in this one, but it helps. It does also block the myostatin activity. It's just a specific compound. And so people are gaining muscle even if they're not exercising because it's shown to do that, independent of like weight lifting, resistance training and things like that. So the GLPs have shown to obviously inhibit that. So that's great. So our interpretation of the data that is out there And our personal experience, because we are measuring it, is that the research is strong, demonstrating that GLP receptor agonists enhance muscle synthesis and amino acid utilization. Hands down, adequate protein and calories have to be where the patient needs to be, basically. Like if you're on these and you're not getting enough protein or calories, I mean, of course you're going to lose muscle. But another missing piece, I think that people are we're in a protein frenzy right now. Everyone's talking about this and we're all buying protein shakes and things like that. And we're all focusing, we finally like know like how much protein we should be eating a day. But if you're not getting enough calories, it doesn't matter how much protein you consume because the body's going to still just use the protein, for the energy. So again, making sure the calories meet the needs as well. Resistance training is critical, especially for those patients who stay on these for a longer periods of time. And that goes without saying. But I think in a shorter term, resistance training, for some people, we all know the patients don't come to us ready to start like resistance training, right? This is a process. So we still feel like we can maintain muscle mass even if we're getting patients to lose weight for a couple weeks without the detriment of like the muscle loss. Our patients lose visceral fat and spare muscle when they follow our guidelines. We just see it over and over again. We just don't have problems with people losing muscle when they're doing all the right things. And there are going to be patients that lose muscle because they're on these GLPs, but they're not taking it as serious as they should to really get the best outcomes. Anyone who loses weight is at risk of losing muscle. It has nothing to do with the GLPs. If you go on any type of weight loss program, you are going to lose a little bit of muscle. So you have to manage it and approach it in the exact same way. Poor diet and poor management is what's contributing to muscle loss, in my opinion. And again, this is just years of now what we have experienced. Okay, so another important thing, especially if you're able to utilize body composition analysis, and for those who don't have access to one, you can easily find local gyms or places that offer like the InBody or like the DEXA. Is it the DEXA scan where your patients can go and do these once a month? Because that's what we do. We weigh our patients a little more frequently, but they do the InBody every month. And so so looking at muscle, not just about the trends of like, okay, where did you start and where's the muscle headed? What's also really important is knowing where where they started from. And actually, I'm going to get to that, but one thing I wanted to point out on this slide is if you are using a like an InBody or a DEXA, find out if say they, 'cause you can see here, skeletal muscle mass so here's the normal range. Anything above there is in the above normal range. So that's positive. But what this body composition assessment does not factor in is the infiltration of the fatty tissue in the muscle. Okay, so you can see the image like this. You can just think of a piece of meat. You have a fatty piece of meat and then you have a lean piece of meat. It's the exact same thing in our body. So if you have a patient that has super high body fat percentage and visceral fat, and you did a body comp and you see that their muscle mass is going down, that may not always be the muscle. That may be, the fatty stuff within the muscle fiber. So kind of keep that in mind and, look at all the different aspects of it. So that leads me to, okay, so this is really hard for me to even see, but what I want to point out is a couple things here. Right here, you see SMM. Hopefully you can see that. That is skeletal muscle mass. So like I said, this right down here is the normal range. This is above normal range for this particular person. So this particular person is starting out with adequate muscle mass. So I always look at where they start, because then you start to look at their trends. So this is like the trends of their muscle mass. You know, he went up, he went down a little bit, went back up, kind of went down, went back up. Going down wouldn't worry me as much because of how much muscle mass he currently has, versus someone like this who has a skeletal mass already in the below normal range. So any loss is, to me, super significant, and it warrants like being more aggressive with interventions. So again, many different things to look at on this, because you look at inflammation, you look at visceral fat. But I did want to point out that, because oftentimes obese people have a lot of muscle, and if you're measuring it, it could be a lot of fatty tissue that's infiltrated in it. So we have a muscle mass guide. I gotta hurry because I always take too long. Okay, we have a muscle mass guide we're gonna provide for you. It has our estimated protein recommendations. This is a great handout to also give to patients, put their starting muscle mass, their current, and what their goal is if you're able to measure it. It really empowers them. I'm gonna go over, I'm gonna have to go really quick on this. So if you can stay later, that would be awesome. But okay, I'm gonna talk about the common side effects, symptoms and side effects. So I'm gonna start with constipation. So it's very important to understand what the root cause of constipation is before just assuming that the patient has constipation now because they started GLP. Looking at the poor diet, gut dysbiosis, do they have SIFO? Do they have SIBO? H. pylori, low stomach acid is a huge contributor. Digestive enzyme productions, if you're doing gut testing, you're going to be able to identify a lot of these things. Are there other medications that they're on that are contributing to constipation, or do they have a medical condition that just they've had constipation their whole life, right? Hypothyroidism, IBS, etc. So really kind of looking at what's going on prior, and then addressing maybe some things that they're experiencing with the GLPs. So it's always going to be the basic stuff when we're working with patients on almost anything. Eat fruits and vegetables, right? Get enough fiber. We found that magnesium is awesome. So magnesium citrate, 200 to 400 milligrams twice daily. You can add some vitamin C, go as high as 4,000 milligrams a day. If you want to try that, I love vitamin C, so we will recommend that on occasion. Magnesium, you can go up to 1,000 milligrams a day. Again, but if you haven't, we have had some people that just start magnesium and everything turns out and they're fine now. Whereas some you're going to get, you haven't addressed the root. So magnesium, one second they stop it, it's all going to come back. So again, looking at it that way. Warm squeezed lemon water throughout the day works wonders. Smooth move tea. We've worked a little bit with prokinetics. I have not worked enough with it to know to give my opinion. On the small number of people, I'd say it wasn't like a super game changer, but I know some people have had a lot of success with it. Adequate fiber and water. Again, just some of the common basics. But if they have a lot of gut issues, like don't tell people to go run out and grab like Metamucil and some of these fiber things, because that'll send them even in a worse situation. And then one of the most easiest things you can do when people are on GLPs is you have to lower the dose, because the higher the dose, if they have constipation, the higher the dose, the more constipation. Reflux, again, did the patient have reflux prior to starting? Look at their diet. Are they eating too fast? Are they not chewing their food? Being overweight or obese already, puts the stress on the body. Low stomach acid, which a ton of people have because we do testing. They have the floppy esophageal sphincter, so addressing, look, again, if you're looking at more gut stuff, but understand just that these are more foundational. PPIs are terrible. Any anti-reflux medications, that's another whole presentation in itself, but that can exacerbate it. And just slow motility. If someone has slow motility in general and then they start a GLP, I mean, it's going to get way worse. And we do see that. We do see if people want to start to, despite like some of the symptoms they're already having, they will see that increase in reflux get even worse, but then they're more forced to like start cleaning other things up. So what do? We lower the dose, we address the constipation, talk about certain things they can do. Chew your food, drink liquids between meals, not with meals. If people are like drinking cold water with meals, that's gonna worsen the GI stuff. You can try to, apple cider vinegar can be great, but again, assuming that they don't have any like ulcers and things like that. And again, always digging deeper if you can. Bloating. So some of the root cause of bloating, asking them, right? Because we're so used to like just assuming it's the medication, but the majority of people have gut dysbiosis. But some of the reasons would be like high amounts of gas producing bacteria, hydrogen, methane, and sulfur. A lot of people are dealing with SIBO and SIFO. I don't think people talk enough about small intestinal fungal overgrowth. It, in my opinion, is probably one of the primary reasons why people are constipated, because the fungus love the cecum and they literally turn off motility. So that's another contributor of bloating and constipation. Food intolerances, are they still eating dairy and gluten? Sugar, alcohols, and foods, terrible, especially Quest products. Certain medications, there are certain diabetes medications that are full of these alcohols that maybe it's not even the food, maybe it's their medications. Obviously, if you're constipated, you're going to be bloated. Are you a gum chewer? Being a gum chewer can cause more bloating. If you drink a lot of carbonated beverages, and if you just have a lot of fluid retention in general. What to do? Always assessing the diet. I'm usually getting people off of dairy unless it's fresh from a farm. Getting them off processed gluten. Lower the dose. Usually with GI stuff, you're staying low. Chewing your food thoroughly, identifying foods that cause symptoms. You can consider some of the motility supplements or the enzymes, and just relax when you're eating, create that environment that allows the body to rest, digest, and all of those important basics. Fatigue. So this slide is specific to the GLPs. We do have a handful of people that when they take the medication, they are tired, like immediately. And so the fatigue for some, it can happen immediately, last an hour, and then it's over, or it lasts for like the whole day, or some people say that they're just more tired. So again, there's a lot to unfold here, but here are just some reasons why the fatigue could be happening. When you take the medication, there's a lot going on in the body, and just that increase in all of the different mechanisms in the GI adverse effects can exacerbate just the feeling of fatigue because the body's going through a lot. It affects the central nervous system, and when there's adjustments in the energy balance and the body is not used to that, that can elicit, more fatigue. There's also effects on some of the neurotransmitters in the brain that can cause more fatigue. GLPs enhance the insulin secretion. They obviously improve the glucose uptake and can again alter the metabolism. So again, the body's adapting to a different metabolic process. Other contributing factors that cannot be ignored are all the other medications that people are on. The liver is overburdened. It has a responsibility to do so many different things, not only from the standard American diet standpoint, but the polypharmacy. So really taking a look at what else the patient is on and seeing if there's opportunities to kind of change some things up. When I think of fatigue, I think of the mitochondria because I wanted to know, okay, so we know that some things could be going on with these GLPs, but is it affecting the mitochondria of the cell? And the studies that I have found is that GLPs can actually improve mitochondrial biogenesis. So that's all positive because we all want improvements in our mitochondria. So that is not the reason for the fatigue. It's probably just the body adjusting and things along those lines. So if they are fatigued, there could be some hypoglycemia. This medication increases insulin secretion, so it could cause a resulting hypo. Assess the diet. Usually people that have fatigue are usually eating kind of crappy. They're eating high sugar, they're eating high fat. So dig deeper into that. Look at the timing of their injection. I will tell people that they can try taking it at night if they get tired, right after. That's something to try. Adding electrolytes and salt to water usually helps people almost immediately. And again, kind of assessing the dose, maybe even dividing up the dose if there is possibilities of maybe it's not common that people would have like a response and a hypoglycemia result, but it can happen. Causes of nausea, I will go really quickly towards this. So the GLPs can affect the central nervous system, a part of the brain that is responsible for emetic stimuli. So these GLPs can cause nausea just by what they do, the receptors in part of the brain. Gastrointestinal effects, obviously. So the delayed gastric emptying can lead to the residual contents staying in the gut for a little bit longer, and that could lead to the nausea. Patient-specific factors, females and diabetic complications have been identified as significant risk factors for nausea and vomiting. So kind of looking at the state of health of the patient and when obviously trying to navigate what could be causing it. The use of proton pump inhibitors or histamine 2 receptor agonists are associated with a higher incidence of nausea and vomiting while they're on GLPs. And let's see, other things. Oh, some things to think about with nausea. Some studies show that switching from semaglutide to tirzepatide can reduce that or eliminate that altogether. Some things to do for nausea: stay hydrated, eat slowly, eat smaller meals, eat low fat for that period of time, avoid spicy foods, alcohol, don't eat and go to bed, don't over exercise after a meal. There's many different, your vagus nerve stimulation techniques. And then we love like our different teas, ginger, lemon, and peppermint ginger can work wonders. And vitamin B6 actually can be really helpful as well. Okay, this is the last slide. I just wanted to talk a little bit about it because I think it's important. I alluded to it a little earlier. Hunger, or appetite suppression, what is our goal, right? Because patients, for the most part, want it to be gone. And that shouldn't be the goal. The goal should be making sure that they're getting satisfied in other things, right? And working on their diet, working on the foundational stuff, and getting them to a point where, yeah, I think it's good to get the food noise to go away because I didn't realize how much of that was going on. These GLPs opened me up to a whole new world of that. But there is a fine line. We do not want to obliterate people's hunger. That's going to teach them nothing. So if someone says, I still am hungry and they've been on, like a higher dose, then it's really time to really start assessing the diet, adjusting dose for whatever that looks like. We do a lot of intermittent fasting for my sickest people who are carb intolerance, just a history of insulin resistance problems will do keto diets for a period of time. You can add supplements that support blood sugar regulation. Again, address any sleep or stress issues. People need to move more. I mean, that's just a no-brainer. Making sure they're hydrated and always looking into other meds, especially as they lose weight. I will talk more about this, but if they're on certain medications for their weight and they start losing weight, they need to be having these conversations with their doctor about adjustments. Okay, so summary, don't just treat the weight loss, treat the whole body. Monitor patients. We also have to monitor the medication because it's such a huge part of it. Define your metrics for monitoring and really know the differences between all the GLP medications because it's not, there's lots of different nuances and ways of doing things. And just because somebody was on semaglutide did horrible, and that doesn't rule them out. I mean, you can get them work on other things and they could start it again and they would be perfectly fine. Okay, so I'm not going to read this just because we're lacking time. You guys can go back and read it if you'd like. We are going to provide some resources in the platform Thinkific, our survey, symptom survey, follow-up survey, and dosing protocols. And I will open it up for any questions. And sorry, I went a little bit over, a lot over. And you can unmute yourself or you can ask a question through the chat. While I'm waiting to see if anyone has any questions that are coming up, Erica has asked me to ask you all to submit any case studies that you might have if you're working with any patients that you are maybe struggling with, or you want some different approaches, different ideas, because she's going to be doing case studies, I believe, next week. And just any other things that might warrant a really good open conversation of like troubleshooting with all of us. So just wanted to put that out there.